As shared by Christos, I work at the Department of Mental Health and Substance Use. I'm the focal point for COVID-19 and mental health and psychosocial support. And I work in the area of supporting mental health programs, particularly in humanitarian settings. Let's move to the next slide, please. You would notice that I'm using in this presentation very commonly the term mental health and psychosocial support. And for some of you who may not be familiar with the use of this term, actually this is a term coined around 15 years ago within the humanitarian system, where most humanitarian actors would use when they refer to mental health issues within the humanitarian system. And the reason is that this term really combines the spectrum of mental health and psychosocial issues by its two components. It's a composite term. The psychosocial aspect, which deals with protection and promotion of psychosocial well-being, and the mental health aspect, which deals with prevention and treatment of mental disorder. And despite for some of us who work in clinical practice, we might not see clearly the distinction because all of us work in prevention, promotion. But the fact is that this area of work is a cross-cutting area. It means that not only health actors need to apply mental health and psychosocial consideration in their work in humanitarian settings, but also protection actors who work in the area of human rights. Colleagues who work exclusively in the area of gender-based violence need to integrate this area into their work. Those who work in nutrition, those who work on camp management and coordination need to make sure while they're establishing the camps and running the camps that mental health and psychosocial aspects are integrated. That's why this is a term that really unites this field. And within the context of COVID-19, the WHO Director General has prioritized mental health and psychosocial support as a cross-cutting area, not only across sectors, but within the health response itself. So we find mental health and psychosocial support, for example, relevant to different pillars of the COVID response. For example, the risk communication aspect, where we need to integrate stress coping messages into the risk communication messages. The clinical management of COVID-19 pillar, where we need to integrate mental health and neurological aspects into the clinical management of COVID-19 itself. The operational and logistics pillar, where we need to integrate mental health and psychosocial aspect into the duty of care of the staff and workers working on COVID-19. Even at the points of entry, where we need to integrate mental health and psychosocial support at quarantine. So it's cross-cutting area, not only across sectors, but within the health sector itself. And it has been recognized as such within COVID-19, which at policy level, we saw as workers in this area as a big achievement. Within the UN system also, we saw in May that the UN Secretary General for the first time has released a policy brief on the need for action for COVID-19 and mental health. This policy brief was a high-level policy event happening at the first time, and recognition of this area as a cross-cutting area in the response, asking to governments to have a whole-of-government approach, not only focusing on whole sector, but engaging also social and education actors while they're responding to mental health needs in relation to COVID-19, and explicitly requesting governments to invest in mental health, not only in the response, but as part also of building back better after the emergency and preparing for the next emergency. So when this policy brief by the UN Secretary General was released in May, the perception from countries was unique. We find that the UN missions, 90 member states delegation have signed a request to the UN requesting more emphasis on mental health as a key component of COVID-19 response. Also, again, another first time, the Global Humanitarian Response Plan, the key document which is released by the Office of Coordination of Humanitarian Affairs, which prioritized 63 humanitarian countries, again, included mental health and psychosocial support as a cross-cutting issue relevant for all its strategic priorities. So the policy environment within COVID-19, because its direct and indirect effect on mental health and well-being, we see it was significantly prioritized. And I say direct and indirect because we know COVID itself have direct effect on mental and neurological health. And we know also that it have indirect effect on the rest of the population, not only COVID patients. people affected by adversity, including the economic turmoil and the disruption of livelihood. And we know that one of the risk factors for mental health condition is adversity. The many vulnerable groups, such as older adults who suffer from loneliness because of physical distancing, children and young adults who are worried about their future, women who may be exposed to gender-based violence and more inequities in some communities, and people affected by humanitarian settings, which already suffering from very limited pre-existing community-based services. So there are a wide range of vulnerable groups. Next slide, please. Thank you. And WHO, together with interagency partners, we have been releasing guidance to a wide range of audience. First, we wanted to guide agencies and humanitarian responders on how to integrate these aspects into their work. So we developed a basic psychosocial skills guide for COVID-19 responders, and we developed it as an illustrated comics book, in fact, because we are not targeting only health responders, but we want to target all essential workers in the context of COVID-19. People who work in transportation, the people who work in grocery stores, people who work in funerals. So a wide range of audience we targeted with this guide on integration of basic psychosocial skills, which was released as a simple comics book. But also for operational agency, we released an operational consideration document for multi-sectoral mental health and psychosocial support program, which included, in fact, a dedicated chapter on substance use and addictive behavior and how to adapt its services in the context of COVID-19 from programmatic aspect. We also, early in the response, we launched a mental health and psychosocial consideration document with recommended key activities that agencies and government need to apply. All these documents, the uptake was huge, and some of these are translated into more than 35 languages since it was released and widely used by government. Some of these documents were released mainly thinking about humanitarian situations, but what we released thinking of countries such as South Sudan, Syria, and Yemen was found relevant, translated, and used in Hungary, in the Netherlands, and in Spain and in Italy, because the context was very relevant and many countries learned from these recommended activities. Next, please. We reached out to clinicians to learn how clinicians all around the world are adapting their practices, including colleagues who work in the area of substance use service. And on the Mental Health Innovation Network, we documented through a blog series and a video series how clinicians from more than 50 countries are adapting their clinical services in the context of COVID-19. Also, we did not release a specific clinical management for mental and neurological manifestation of COVID-19, but we integrated a chapter on mental and neurological aspects into the formal publication for management clinical issues related. And we covered there specifically issues such as depression and anxiety, insomnia, and delirium, and how to manage among moderate to severe cases of COVID-19. And in fact, this guidance is updated. Guidance usually is updated every 2 months. So in the next release that we are working on, expected to be released by next month, we are also include further guidance on mental health and psychosocial aspects of mild COVID cases. Next slide, please. And the area which grow with COVID based on the need from communities and countries was advice to the public. So risk communication messages that was adapted widely was released early in the response, a self-help guide that was developed actually before COVID-19 and was developed as a document to be self-read and called Self-Help Plus, an illustrated guide for people, for the public to read and support them in coping with stressors with accompanying audiobooks. And I'm putting here the picture of an interesting project that we worked on early in the response. In March, we started working on. We wanted to develop messages for children, and we asked children, parents, and teachers from 100 countries. We got responses from 2,000 children and their parents and teacher, and we developed the story to give advice for children and their parents on how to deal with emotional aspects related to COVID-19. This story uptake was remarkable. We released it only in 6 languages, now on the website. I shared the link with ISAM colleagues. You will find it available in 126 local languages, making it one of the most translated ever books that was released. In fact, in history, by having 126 translation with numerous adaptations, including in Braille for children with blindness, in sign languages, in numerous languages, and also as an animation, video and audio for children with visual problems. Next slide, please. WHO and partners, we worked in wide areas of our country support with specific focus on lower income countries. So a rapid deployment surge support mechanism was activated since March. We had about 12 deployments for countries requesting deployments to support mental health and psychosocial support coordination. And the images you see here is for a wide range of adaptations for some of the materials that you saw in the previous slide. So you see the children's storybook adapted, in fact, by Johns Hopkins University for the context in Turtle Island for Native Indian Americans in the USA through an intertribal workshop with the Native Indian Americans. Other pictures include adaptations from Indonesia, from Greece, from Georgia, and the last one here you see, in fact, from Gaza, where it was adapted into a radio series. So what we developed sitting in Geneva and in partnership with colleagues sitting in the field need to be taken when it reached Turtle Island or it reached Gaza to be adapted for the local population. Next, please. And more snapshots from what's happening in countries in this area of work, the mental health and psychosocial support. The first image is for an intervention. When we asked countries what they use to adjust to services, many countries said they are using helplines. And this is, in fact, is a helpline used in Syria in the middle of war to support mental health and psychosocial well-being. And the training happened in Turkey, but these are the colleagues who are running the helpline in Idlib in northwest of Syria. Next, please. And this, in fact, from Yemen, messages which are developed need to be culturally adapted and cannot be disseminated widely without adaptation. And you see here the interesting adaptation for the messages culturally fit for Yemen. But the beauty of technology now is that you can reach where humanitarian workers cannot reach. We may not be able to reach everywhere in Yemen, but using WhatsApp, you can send it to health worker coping messages like this, with Yemen having one of the highest mortality rates of COVID-19 in the world. Next, please. This is in Philippines, where there was a very good coordination system for mental health operations in the middle of COVID, but relied totally on having a system of focal point. In every health facility, there is someone responsible for mental health and psychosocial support, and they have weekly meetings through this system of focal point. Another use of innovation and technology, but this time for coordinating the response through a system of focal points. Next, please. And this one from Ukraine. And the message you see is in Ukrainian for adapting some of messages related to harm reduction, related to drugs and alcohol in a country known to have high consumption rates of substance. So this is a message for health worker on coping with stress, avoiding harmful negative coping mechanism. And in the other message, you see also integration of mental health into primary healthcare supervision. We cannot do training on integration for mental health and general healthcare, particularly in the area of the east of the country, where there is large percentage of displaced population without supervision. But supervision has to be shifted online in the image you see here. Next picture, please. This is from Lebanon, a country responding to COVID-19 and then affected by the blast, and there was need to support young people. And creative colleagues from UNICEF and WHO had the idea of developing KEFAK, or How Are You? It's online support groups for young people, usually run by young people, but a psychiatrist or a psychologist who's intervene only for psychoeducation. But it's mainly an initiative run by young people. And they tackled several topics. One of them was using alcohol and using substance as a negative method of coping. But here it's young people sharing information, sharing what they do and the positive coping mechanism, and the mental health professional deal only or intervene only to provide psychoeducation. Next, please.
1 minute, Pakmi,
sure.
Yeah.
And and for people with severe mental health conditions and very difficult to reach areas and places, again, like Syria, mobile teams start to replace services which has been disrupted. I use just the snapshots from I know very extreme and very challenging situations to show innovations colleagues are using there, but from many other countries, examples are available for what countries are doing. But what we know is that mental health and psychosocial issues in situations either in conflict or situations such as infectious disease outbreak with a scale like this one are not short-term issues. We know that these are long-term issues, and the impact of this would continue for years even after the situation resolves. Thank you.
Thank you to Dr. Khanna. Kelly Knight is going to talk about stigma and COVID. Kelly, the floor is yours.
Great, thank you. And thank you for the invitation to speak with the group today. So my name is Kelly Knight, and I'm a medical anthropologist at University of California, San Francisco, where I'm associate professor and vice chair of our medical anthropology and medical humanities department. And I'm also the faculty lead for addiction medicine curriculum for the undergraduates, and do a lot of work with structural competency and addiction medicine, which I'm happy to talk about if people are interested. But I'm here today to talk a little bit about some studies that I'm doing in relationship to people with substance use disorders, mostly in the Bay Area in California, where I'm located. So next slide, please. So I think just to start, I think it's important to recognize that when we think about COVID-19 and substance use disorder in the United States context, it's deeply shaped by structural racism in terms of both the vulnerability to COVID-19 and to substance use disorder, the lived experience of substance use disorders and COVID-19, and also the clinical trajectories or outcomes for people with those co-occurring conditions or at risk for either. And so when we think about implicit frameworks that involve sort of lifestyle explanations or behavioral choices, those explanations or that orientation and that framework can has the potential to perpetuate stigma, both in terms of internalized stigma and also enacted stigma in clinical and other settings. And we see with both COVID-19 and substance use disorder in the United States, since sort of things really escalated in late February and early March, that the structural determinants such as access to housing, access to technology, and low-wage labor are creating significant barriers to COVID-19 safety and to access to care for people with substance use disorder. So I'm just going to give a few examples. Next slide, please. But first, I kind of wanted to frame the way that I think about stigma and share this article by Sai and colleagues that came out actually pre-COVID called Stigma as a Fundamental Hindrance to the United States Opioid Overdose Crisis Response. So this was focused on the opioid overdose crisis in the US, but is a nice framing, I think, for thinking about how stigma operates for people with substance use disorders and those who provide care to them. And they really organize it around the idea of public stigma, which has to do with stereotypes, for example, for people with substance use disorders, how they're perceived in the public and how those stereotypes circulate, the ways that those stereotypes can produce anticipated stigma for people with substance use disorders when they think about accessing care or other services, entitlement services, housing services. That stigma can also be, of course, internalized within people with substance use disorders to create stigmatized identities of devalued status, which affects their interaction with healthcare. Enacted stigma in their framework and others really speaks to experiences of discrimination and social distancing. So the way that we pay attention to this and train on it at UCSF is particularly in the clinical care context. So the ways in which people with substance use disorder might have internalized or anticipated stigma coming into healthcare environments, whether for COVID-19 testing, care, or for the management of their substance use disorder, and how they can be on the receiving end of enacted stigma by their healthcare providers. And of course, family members and other people within the social networks of people with substance use disorder can also enact and experience the stigmas associated And then structural stigma, I think, is really important and interesting, which really reflects the ways in which these multiple forms of stigma can interact and become mutually reinforced in institution norms and policies. And so I'm going to focus a little bit on the relationship between structural interventions to respond to COVID-19 in the US context and their potential to mediate these multiple forms of stigma. Next slide. So these are 3 studies I'm going to draw on that I'm leading currently in the Bay Area in California. The first is an NIH study that is part of a work that I've been doing, a couple of different R01s that I've had from the National Institutes of Health and NIDA for about 10 years. And it's focused on primary care providers and patients with co-occurring chronic non-cancer pain and substance use. Primarily opioid use disorder. So this is kind of right in the middle of the opioid overdose crisis and the response to reductions in prescribing of opioids in the US context. And what we've seen with this cohort of patients and providers since COVID-19 are, first of all, most of the patients, about 80% of the patients in this cohort, this is a qualitative ethnographic study, because I'm an anthropologist and that's the kind of work I do. So we have about 50 patients in this cohort, and 80% of them have 3 additional chronic conditions in addition to opioid use disorder and chronic pain. So COPD is really common, or hypertension, all of the conditions that make clinical outcomes for COVID severe and concerning. There was also, we've seen a lot of return to use among this population and increased substance use in response to anxiety and depression and isolation that have resulted from COVID-19. There's been a transition to telemedicine that happened completely instantly sort of in March, and then has been slowly changing back to a hybrid model of telemedicine for primary care. But that's been something that we've been tracking really carefully to see who is able to interact with telemedicine for primary care, for their chronic conditions, their pain, their opioid use disorder management. And then a lot of COVID stigma and fear amongst this population of, this is a safety net population, so these are all underinsured or low income patients in the Bay Area. The second study that I've been doing is actually at an OTOP program and an opioid treatment program that prescribes methadone and buprenorphine. And we're looking in that study on how the medications for opioid use disorder delivery have been changed by regulatory and care practice changes that happened at the federal level in the US in early March. Some of those include a relaxation of regulations around who can get take-home doses for methadone, changes in the ways that buprenorphine inductions can happen over the phone as opposed to with an in-person visit, reductions in counseling, which I think is really relevant to today's topic in terms of the way that that medication access has been decoupled from required counseling, which was one of the regulatory pieces of methadone delivery in the US for many, many decades. And then one of the things we've been tracking really carefully is for those who are suspected, who have a COVID exposure or who test positive for COVID-19 and are put in INQ, which are isolation and quarantine hotel rooms in San Francisco, how is mood being supported? How are people's treatment trajectories not being disrupted and being managed effectively in those settings? And we have a paper coming out looking at how that's happened. And lastly, we were doing a study in California of harm reduction programs, the ways that they were responding to people with substance use, mental health, and housing challenges, all of those co-occurring, and in the middle of COVID. And so we were able to look at how those programs had to reorganize and respond to COVID-19 being essential workers. So how needle exchange programs stayed open, for example, and other harm reduction services. So those are kind of some of the challenges that we've been able to identify in this work. Of course, it's ongoing, but I'm going to mention a few of the structural interventions that we see have been effective here, and that we've heard from program patients and providers seem to be making a difference. So, but first I want to just, next slide, please. I want to just acknowledge my staff who works with me. This is the staff that works on the MAH project, where we do ethnographic work with both the patients and providers in primary care settings. And then next slide. This is the slide of some of the harm reduction program work, and you can see the ways that we have transitioned in our work from doing site visits of harm reduction programs to actually doing Zoom-based interviews with them to safely assess how they're responding to the COVID-19 pandemic. Next slide. So what we see, particularly in primary care, is that we're moving from this clinical setting, which is San Francisco General Hospital in the Bay Area, to next slide, to people trying to do care on their phones. And whether or not people have access to phones, whether they have minutes on their phones, whether or not they're prioritizing keeping those minutes funded on their phones to be able to stay in touch with their behavioral health or primary care versus being able to pay rent or being able to buy food for their families is an ongoing challenge. And there's been some structural interventions around that I think have been and are important to note. There's also a lot of issues in the moves to telemedicine with confidentiality, with privacy, with safety from violence and conflict within home settings or environments where people are living, where they might not be able to have conversations about what's really going on in their needs because they're no longer private in a clinical setting. Next slide. We also see interventions in the Bay Area around housing, and we have a really, really large population of people here experiencing homelessness, and there's a lot of city and state level interventions in response to COVID that we are studying carefully to look at how the impact, what impacts that may be having on people's substance use, their mental health, and also, of course, their COVID safety. So we see a lot of settings this is just from downtown San Francisco, where people have a lot of difficulty social distancing, and are still interacting at a level that produces a significant amount of COVID risk. And then on my right-hand side, I'm not sure what side it'll be on you, is a picture of a safe sleeping site that's been set up with tent camps at social distance to be able to provide an interim for people can maybe get into shelter-in-place hotels, which have not been. That's a long story, but have not been a straight shot from street-based settings to these safe sleeping sites to hotel rooms, at least in San Francisco. Next slide. This is a picture of a outdoor methadone van delivery. So one of the things that the methadone program that I'm working with and studying now did was basically move methadone outside. So to depopulate and decongregate the clinical waiting rooms, they set up a van site about a block away from the clinic and have been running an outdoor site in order to promote COVID safety and make sure that people don't have disruptions in care. So that's one of the things that I'm examining. Next slide. So structural interventions. So I mentioned some of the housing interventions for COVID vulnerable people, including isolation, quarantine, SIP rooms, and safe sleeping sites. We've been hearing from our providers that people's treatment trajectories have been improving dramatically with housing. That's not a surprise. We knew that before COVID. But COVID-19 has enabled some of these interventions to move much more quickly in the United States. The changes to the take-home rules, particularly relaxation of co-use of stimulants and methadone, for example, that have been pretty successful. They haven't had the poor outcomes that some people were worried about, is another regulatory intervention. Reconfigurations of care, I mentioned the van sites. We had one program get a donation of a bunch of flip phones, so people would have access to phones with minutes on them so that they could initially stay in touch with their counselors and care. There's also been a focus on training clinical staff in harm reduction practices, especially in the SIP hotels. And then we have an addiction telemedicine program, which I mentioned, helping with the buprenorphine starts that we have a paper on that looked at being able to reduce barriers and disruptions to care during COVID for people on buprenorphine. Next. So how do these relate to stigma? again, moving away from these lifestyle explanations and thinking about some of these structural interventions that hold a lot of promise for people, both for COVID-19 safety, prevention, and response for people who've become infected, is that, you know, we can help manage by reducing concentrated poverty. We can help manage public stigma for people with substance use disorders, especially those experiencing homelessness. By creating low threshold services through these interventions, we can help with anticipated stigma because people with substance use disorders don't carry the risk that their treatment access will be disrupted or lost. It also reflects, it helps reduce feelings of neglect and unworthiness that are related to internalized stigma if people with substance use disorders continue to feel cared for and not left behind in the COVID-19 pandemic. Training and service provision help reduce enacted stigma because providers have successful experiences managing substance use disorder in the context of a pandemic. And then we have the increased possibility to institutionalize and regulate promising structural solutions, which is going to obviously impact structural stigma because these are all very related. So thank you. That's what I had to share today, and I appreciate your time.
Kelly, thank you very much for this excellent presentation. Kathleen Brady is going to talk about COVID and the impact on women in USA. And Kathleen is going to have 15 minutes just because she's going to expand on women, on the impact on women in more detail. So it's not the usual 5-minute feedback from the individual countries. It's an extended presentation. Kathleen, thank you. The floor is yours.
Okay. So I will veer to talk a little bit about how some of these things impact women in particular. If I could have the first slide. And I want to just tell both of the presenters this morning, I really appreciate their comments. They have been very useful, and I'll try not to repeat some of the things Kelly said as I talk about the situation in the United States. But this is a couple of weeks old, the COVID dashboard that comes from Hopkins, and you can see the United States has a pretty bad case of the COVID-19, lots of infections, lots of deaths. We just passed 200,000. And so you can see there's very dense infection in the United States. Next slide. This just looks at the US compared to other countries, again, from the Hopkins dashboard. And you can see with India and Brazil, we're up there. These are just daily new confirmed cases, but deaths look about the same. These graphs look about the same for deaths. Next slide. And this is drug overdose deaths, not just opiates, but any drug overdose deaths in the United States. And everybody knows they have been increasing as over the last 20 years, but you know, in 2018, you see that little dip there. We were all rejoicing. We thought we had maybe made a dent. There were many, many, many federal efforts that actually, there was money that flowed down to the states to improve treatment, improve access to medication-assisted treatment in particular. We thought maybe we had made a dent, but 2019, the numbers were up again. And then if the next slide, I just want to show you what is likely to happen in 2020. We can be certain that there will be a rise in drug-related deaths in 2019. This is looking across some individual states. Delaware, so far this year, they have had a 60% increase in drug overdose deaths. Washington State, 35%. I don't have to show you the rest of the numbers. You can just see drug-related deaths have risen tremendously in 2020. Next slide. This is in South Carolina, where I live, and we're just talking about the responses to opioid overdose. So this is EMS response. The green line is 2019 monthly. The red line is 2020 monthly, and you can see that it tracks extremely well with the onset of COVID in our country. With the onset of our awareness of COVID and with the shutdown. Now, why do we think this is happening? Well, I think Kelly gave us a few good hints about that. One is that there's been interruptions in the supply, both the illicit supply, because believe it or not, drug treatment settings actually shut down. Some did. There have been interruptions in the illicit supply, just as there have been interruptions in the illicit supply chain of everything. There's been interruptions in the illicit supply chain. And so what happens is people are out for a few days, their tolerance decreases, they access to drug, and they overdose. That's one explanation. The other is likely that really the isolation, the anxiety, and the lack of treatment access, the lack of any sort of emergency. This graph here is actually kind of encouraging because it shows EMS responding to opioid overdoses. In many states, we have heard that the emergency medical services do not prioritize these days opioid overdoses because they have so many response to COVID and other related emergencies that when they need to prioritize, again, we're working with a very stigmatized population, not always prioritized when times get tough. If I could have the next slide. We know that COVID-19 and the addictions as well as psychiatric illness has really been the perfect storm. We have always been dealing with a very marginalized and stigmatized population anyway. So when services are short, when things are being cut down, our population is likely to be the first one cut out of the loop. Also, stigmatization and that internalization of stigmatization makes folks less likely to seek services even when they need them. Add to that the fact that they are vulnerable to all of the medical consequences of COVID-19, much more so as a result of their substance use, medical consequences of the substance use. Many of our folks have been smoking, vaping, and their lung function is compromised to begin with. Opioids already have the impact of decreasing respiratory function. Many of our people are immunocompromised either because of other infection or simply because of malnutrition and poor eating habits. In addition, add to that the fact that the systems for providing care are very fragmented. And in the United States, I think perhaps more than many of the other European countries, at least, our system for providing substance use care have really developed outside of the general medical system. So they really, and referral back and forth between the two is not necessarily a simple and automatic process. If I could have the next slide. So I can just give you, and in terms of not just physical vulnerability, our folks have tremendous socioeconomic vulnerability. They are often the people who have the jobs that are the first to go, people working in the food and beverage industry, people working in the hospitality industry. That has all gone down the tubes. So job loss then gets coupled with housing instability, which are two things that really make people much more vulnerable, both to falling back into addiction as well as being more susceptible to being exposed to COVID-19. Domestic violence has turned out to be a particular problem. I'm sure not just in the United States, I'm sure this is everywhere, but calls to hotlines have quadrupled in the, since March. It is a particular problem for women. Women are more often than men happen to be the victims of this domestic violence. And, we have shelters for domestic violence, but I'll talk about this in a minute. A lot of those shelters shut down because of COVID-19. How to safely distance in a residential program and still make your bottom line is something that many programs are still trying to figure out. So often we would invite, when you via these domestic violence hotlines, we would invite people to come to a shelter and bring their children, and that's not a viable option in many places these days. There is also just the social isolation is really something, and the anxiety and the loneliness that goes along with that, I think, are also vulnerabilities for our population. Next slide. So the agencies that we did a survey in South Carolina, we're a rural state. Many of our, and as I said, in the United States, the addictions treatment system grew up sort of outside of the general medical system. And in many of our agencies, until they started providing medication-assisted treatment, they didn't even have physicians or nurses or any sort of medical treatment providers in their agencies or on site. So when permission was given, or when not permission, orders were given to shut down all non-essential services, that's what happened. Non-essential services initially were told to shut down. Many of our substance abuse treatment agencies shut down. We had to call our state director and say, you need to let your people know that they are essential agencies. This kind of blew my mind, but I was really amazed. Patients were flooding into us saying, there's no answer. It says that the Dorchester Drug and Alcohol Commission is going to be closed for the near future. And these were people that were on medication-assisted treatment. They were people, so they were slow to respond. They eventually did, many moved over to telehealth and are still on telehealth. But many of those agencies closed for a week or two while they tried to figure out how they were going to respond to this new situation. Residential programs across the state all closed. I'm not aware of any residential programs that did not initially in the first week or two close. Now, again, many of those have opened up, many of them regrouped. Now they have rooms for single people. They have ways of social distancing. They're providing, they got the proper disinfectant and all that kind of stuff, but nobody had that on hand. So residential programs closed and now are slowly reopening. If they have federal or state monies, they can stay open. If not, it's going to be difficult because of the distancing rules. They cannot their patient flow isn't good enough for them to make it financially. And there is also patient reluctance to go into these residential programs now. And this is one of the areas where I'd say it really impacts women in particular. We have had a very nice safety net system for domestic violence where people can come into residential settings. And we've had a very nice safety net system for pregnant women where they can come into a residential program and even deliver their baby and stay there for the first year. All of those are either closed down or their capacity is cut in about to about a quarter of what it once was. So that is a huge. Emergency rooms are, as you can imagine, overcrowded with COVID and people are reluctant to come in. So we've had a lot of places. We had a lot of systems where they were starting people in on buprenorphine if they came in withdrawal, and then actually doing a warm handoff to for a referral. And many of those are saying at this point we don't have the time for that. So they're a lot of the buprenorphine initiation emergency rooms has shut down, and then EMS rescue and overdose services have been really taxed because they're getting called all over the place. Next slide. There have been some decent responses that I hope some of this will improve our system over the long run. Federally funded systems, I mentioned this earlier, that's why we think we had a big decrease in overdose in 2018. The federally funded treatment system had many gains. There was this 20th Century Cures Act gave a lot of money to improve access to medication-assisted treatment for opioid dependence. 2017 and 2020, and we first thought we were reaping those benefits in 2018, and we're very worried about losing those gains. But one of the things that's happened is a lot of, not only the federal government was the first to really relax its rules around telehealth billing. Telehealth billing used to be a huge sort of controversy. You'd get paid about a quarter of what you got paid if you saw the person in service. There were all kinds of things that really worked against telehealth. Telehealth billing has increased 8 1,000-fold in the United States in 2020. Insurance and Medicaid, both our federal insurance and our private insurance, are now covering these visits close to the same amount of money they would for a face-to-face. Federal guidelines have relaxed. You're now able to prescribe buprenorphine without an in-person visit. I think, Kelly, that was a huge step forward. Most states would not allow you to prescribe. And there has been federal guidance about encouraging more take-home dosing for methadone. As Kelly mentioned, you can now give methadone and buprenorphine with less less of the counseling visits. I mean, that may be good or bad. I mean, that, the access to less counseling is not necessarily a good thing, but if people can get their medication-assisted treatment more readily, I think that's something that we would all applaud. Take-home dosing is actually encouraged by SAMHSA and by the federal government. That's never been the case for methadone. And in some states, we've had an expansion via mobile treatment units. If I could have the next slide. So I think our big question coming up is, we are monitoring closely. We've got a couple of studies, the impact of loosening these regulations, because what we'd like to see eventually is us to consider revising some of these regulations. Is an in-person visit really necessary before initiating buprenorphine? And in truth, I think what we're going to end up with is some sort of a hybrid system. We all know that in-person visits can be important. We all know that group therapy is a process that can work very well for our patients and can help get them support both inside and outside of the treatment facility. And group sessions, I don't think anybody's really figured out a way to make them work quite as well via telehealth. So, and also residential programs will be needed for some. And I really hope our pregnancy residential and some of the domestic violence shelters have reopened. But I think we're going to end up with a hybrid system where we're going to do a lot more via telehealth than we ever did before. But we really do need to reintroduce some of these vital face-to-face services as COVID permits. And that's all I had to say.
Kathleen, thank you very much. Very much on time delivery. Very interesting to see how the situation evolves in USA. Can we move now to Brazil? And Felix Kessler is going to give us feedback from Brazil.
It's a pleasure to be here with you again. Last time, a few months ago, my presentation was focused on the worrisome numbers of COVID pandemic in Brazil that were increasing quickly. And today we are getting the third highest death tolls in the world. So we're still very worried about it. But I'm not going to talk about that. This time I prepared a more positive presentation. So I will show you some of the good initiatives we are doing in the country in order to help people with mental health problems and disorders and stress symptoms. I will make a very brief presentations on what we are learning about telepsychiatry, telepsychology, and psychotherapy online. So in this slide, you can see 3 hotlines that are being offered to the population. The first one from our state. The second one is a nationwide with higher number of people calling, average 30 calls a day currently. And the third one is from a single hospital in our city, Porto Alegre, in the south of Brazil. One of the interesting findings of this interventions program is that they need to be extremely connected to the media. They must be advertised all the time, which can be difficult and sometimes expensive. People are not used to call spontaneously to ask for help, and this may be a culture that we need to change in the country. You can see the peaks in the graph of calls after television shows, advertisement. We had the same experience with a substance abuse 24-hour hotline that we had in Brazil for almost 10 years. Drug users and families had very low compliances to the interventions we offered as motivational interview and CBT. Please, the next slide. In this slide, we see the main program in the country, which is coordinated by our university in collaboration with the Ministry of Health. Actually, it's a large trial where patients, mostly health professionals and teachers who are suffering in the front line, are randomized for interventions with CBT, interpersonal therapy, and preventive groups with psychoeducation videos organized and applied by trained professionals. Next one, please. Interestingly, only a few people complain about substance abuse. Most of them seek help for symptoms related to anxiety, exhaustion, as you can see, depression, loneliness, fear, and outbursts. Hopefully, in the future, maybe in the end of the year, we can present the results of the trials. Next one, please. In this other hotline from our state, with a group of 12 psychological and psychiatric institutions, with more than 800 psychiatrists and psychologists, the mean age of people who are seeking help was 36 years old, and we received many calls from elderly people feeling lonely, and from families asking tips on how to deal with kids and adolescents during quarantine. Again, only a few calls about marijuana and alcohol. Please, the last one. Finally, we just published a letter about substance abuse in the context of pandemic, which is available online. We think telemedicine and apps are potential tools that can be more explored in the future in order to prevent and treat people with addiction disorders. But we still have challenges to overcome, especially how to assess these people and how to increase adherence to it. Thank you very much.
Felix, thank you very much for this very interesting presentation. Should we move now to Norway and Gabriel Willestrand? Gabriel, the floor is yours.
Thank you very much. At the last webinar, I told you about a study we're about to start, and we started just a week after we had the webinar. And this is a study on the way among people who use drugs in 3 cities in Norway. And it was published last week in the first part of it in Drug and Alcohol Dependence. Next slide, please. As in any other country, we have had a growing concern regarding the risk of COVID-19 among persons who use drugs in Norway. Norway is a fairly rich country. It's a large country with few inhabitants. And our society was partly closed down on March 12th due to COVID-19. And from April 20th, we had a gradual reopening of the society again. I was working as a doctor on an isolation unit for substance users, and we got very few patients in there, and we were wondering what was happening. So we wanted to, therefore we started this study, and we wanted to examine the respondents' knowledge of COVID-19 symptoms, if they had any present COVID-19 symptoms, if they were willing to take a COVID-19 test, if they experienced any symptoms, and if they knew about the services available to COVID-19 positive substance users in Oslo and Bergen. We also explored the drug availability and the prices of drugs. Next slide, please. We included a total of 226 people who used drugs between May 13th and June 30th in Oslo, Bergen, and Kristiansand in this cross-sectional study. We have continued this study, and now we have approximately 400 participants. It was an interview-administered question, which took 3 to 5 minutes, very simple interview, which we had made together with different professionals and peer workers. We included also intervention. If the respondents didn't know about the symptoms of COVID-19 or the services available, the interviewers were asked to inform them about them. And the interviewers were peers, former drug users, and professional at low threshold services in the cities. Next slide, please. So the background characteristic of these 226 substance users, 73% were male. The mean age was 44 years, but ranging from 18 to 80. 55% were currently in opioid maintenance treatment. And when it concerned their current drug use, we put together their main drug of use and other substances they used. 61% used cocaine, amphetamine, 60% used cannabis, 55% used heroin or other opiates they bought illegally, 52% used tranquilizers, and 33% used alcohol. 55% of them injected. So what is the answer to the COVID-19 questions? 2/3 of our cohort were familiar with COVID-19 symptoms, but they had surprisingly little symptoms when you know how many other comorbid somatic diseases they had. It was only 20% who reported body pain, aches, and 17% reported shortness of breath, and 12% reported cough, and even less for the other symptoms of COVID-19. More than 90% stated they would take a test if they experienced COVID-19 related symptoms. But 2/3 were not aware of the specially designed COVID-19 services available to substance users needing isolation. Next slide, please. 1/3 of the cohort reported the current drug shortage, and mostly of those, 1/3 reported this for tranquilizers and a bit less than 10% for cannabis. 2/3 reported an increase in drug prices, and of those, 70% reported this for cannabis. We also found that those in opioid maintenance treatment had higher odds of being familiar with COVID-19 symptoms, and they also had higher odds of being aware of services available to COVID-19 positive substance users. And the last slide, please. So our conclusions or take-home messages are opioid maintenance treatment, or probably any drug treatment, may play an important role in COVID-19 prevention. A special effort is needed to reach people who use drugs not in treatment, and more information is needed among substance users about the symptoms of COVID-19. And it will be important to ensure information about test availability, easy access to test facilities, and proper care of those testing positive. And we also think there is a clear need for tailoring messaging specifically towards vulnerable groups. And that was the end of my presentation.
Gabriel, thank you very much. I have to say I'm jealous you were able to do this survey with service users, something that I wasn't able to do in Greece. So yeah, well done. Very useful information. Let's move on to Sweden and Martin Kaberg. Sweden has been an outlier. As far as I know, they haven't followed the measures that the rest of the world has followed. So I would be extremely interesting to see the challenges that professionals and clients with substance use disorder have faced during the pandemic. Martin, the floor is yours.
Thank you so much, and thank you for the invitation. Yeah, correct. We had another approach, and I will, in this talk, focus on mental health and substance use disorder care impact mainly in Stockholm, where we had the epicenter of the COVID pandemic. Next slide, please. So as you can see, the peak of ICU cases and mortality was in April. And since then, we've seen a decrease in cases and mortality. And the peak of positive cases in June was due to increased testing, and the high level of testing have continued, but with a low prevalence of new cases. We're seeing a mild increase in cases at this point, but not compared to the rest of Europe at the same magnitude. Next slide, please. So this is seroprevalence data from healthy blood donors in 3 Swedish regions. And as you can see in Stockholm, there was a fairly high prevalence of antibody positivity, around 12%, not of course taking into account the T-cell immunity. I will get back to this later. Next slide. So we also anticipated a high prevalence and a high disease burden among patients with substance use disorder and psychiatric disorders due to problems with physical distancing and homelessness and living in shelters, and also difficulties to manage hygiene in a proper way. But as you can see, we had in Sweden 1,000 psychiatric inpatient beds, and the overall peak was in April, and you could see we had 17 patients admitted, corresponding to 1.7%. And if you just look at this is a variety of psychiatric clinics, but as you can see, if you just look at the dependency disorder clinic, we had 3 out of 67 beds with COVID positivity a bit later in May, corresponding to 4.5%. But since the last month, we have seen no cases as inpatients. And next slide, or next click. Yeah, and accumulated over time, you can see that we had overall 100 patients positive for COVID, and at the dependency clinic, only 20. So we're quite surprised, actually. Next slide. So when we look at emergency visits at our fairly large specific dependency disorder ER, we could see a decrease in emergency visits in April, about 20%. But as you can see, since June, we're back to normal flows with around 60 patients per day. Next slide. And also when we look at occupied beds for inpatients, we would see a decrease around 20% in June, but now back to normal flows. We did not see any increased rates of suicide, and we haven't detected increased rates of overdoses, but it's too early to draw any firm conclusions, I would say. Next slide. There are some benefits due to COVID, and we could see a sharp increase in transition to telemedicine. There were also some pragmatic solutions to some problems we had for our patients with outside clinics for OAT patients, and also home visits. On the backside, we saw a reduction of group therapies, but the increase in telemedicine and outpatient contacts did not necessarily target the most vulnerable patients group. So the last 2 slides, just a report from our harm reduction unit, the needle exchange in Stockholm. Next slide, please. We could see a pattern where we saw a 42% decrease in people injecting heroin, and this was also met up by increased transferal to OAT treatment during the period. Next slide, please. So we have an ongoing study, very much like the one in Norway, but I will only present the COVID antibody tests. And we've so far tested 536 out of 1,100 patients coming to the needle exchange. That's almost half of all the patients during this time period. And we can see that the seroprevalence among people who inject drugs in Stockholm is only 6%. So it seems like they're less exposed, at least producing antibodies compared to the normal population. So in summary, I would say that we've seen an acute decrease in acute and non-acute visits, around 20%. We didn't see any specific patient groups that didn't go to the acute emergency units or outpatient clinics. Maybe some effect on heroin use. We have had all services open. We have had no shutdown, and since June we're pretty much back to normal. Thanks.
Thank you, Martin. Extremely interesting picture from Sweden. Sung Yang, the floor is yours.
Thank you for inviting me this webinar, and also thank you for giving me the opportunity to present the my name is Sung Ho, and I'm working at Busan National University Yangsan Hospital, and I'm also served as a director of the Yangsan Community Addiction Management Center. This is the first time for me to present online in English, and I'm not good at English, so I asked for your understanding of that. Korea has maintained social distance since the first confirmed case of COVID-19 occurred in February. According to the survey conducted by Korean Addiction Forum, during the maintaining social distance, there were increase of anxiety and depression, and there were difficulty in treatment seeking, and there were increase of urge to seek pleasure to escape negative emotions. It leads to the occurrence of various addiction problem, and the increase the risk of recurrence of existing addiction problems. However, due to limited operation or shutdown of Community Addiction Management Center and rehabilitation facility in Korea, the risk of addiction problem is increasing. Comparing to first half of 2019 to first half of 2020, the new registration rate and short-term intervention rate and the active management rate has been decreased, but relapse rate has been increased. Obtained the data from community addiction management centers in Korea. This is thought to be due to a difficulty in preventing and promotion activities and prohibiting visit by public health centers, and also having difficulty in managing cases, work with hospitals, and difficulty in providing face-to-face services. Therefore, effective standards and systems of COVID-19 area will be needed, including establishing non-face-to-face services with minimal physical contact, and also coordinating crisis intervention manuals tailored to COVID-19 area. The EU registration rate has decreased to 25% to 30.5%, and but the election rate is increased to 21.9% to 32.8%. As I mentioned, this is because difficulty in promotions and most of centers shut down or reduce the programs. I think effective standards or system of COVID-19 area will be needed. I prepared just one slide. This is the end of my presentation, and thank you for attention.
Thank you very much, Young, for the presentation. Now, the last presentation, last feedback from Australia. Shalini is going to do this presentation. Shalini, you have plenty of time, as much time as you want.
So I'm just going to present briefly on Australia and the situation here. Next slide, Jenna. So our situation in Australia, I mean, I think some of the numbers we've heard from some of the other countries, you know, in the context of that, we haven't experienced a huge number of cases, but I guess from the graph that you can see, what we have experienced is a second wave, essentially, and the large proportion of that second wave experienced in one state, in Victoria, and in the city largely of Melbourne, where I am in. And you can see that those photos there of Melbourne, normally these streets would be packed, and we've been in lockdown for essentially now in some form of lockdown for about 6 to 7 months. So, I mean, I think, you know, here we are talking about sort of impact on mental health. We can kind of all appreciate the effect of that and what that's been like. I think internationally, the concept of 6 to 7 months in some period of lockdown. We've had curfews in our city as well, from after sort of 8 o'clock or 9 o'clock. And so these streets normally would be very busy and are completely empty. In the context of that and in context of services that have operated, we've had addiction and mental health services operate as essential health services through the entire period. And what we've seen is, as mentioned by many of the other presenters, a very rapid switch to telehealth and a really rapid uptake of telehealth. But I think as Kelly was mentioning before, I think what we've seen is also that some of our patients are significantly affected by being disadvantaged by that switch, in the sense that there's a definite sort of digital divide that we're seeing, that people don't necessarily have data access. A lot of the video type telehealth appointments are very data intensive. And that means that, you know, a lot of our pharmacotherapy clients, in particular methadone and buprenorphine clients, are doing telephone consultations instead of video consultations, not always being necessarily their preference, but not having data plans. So I think that's really, you know, been part of the piece for a lot of people. I think the other part of that is that, you know, going forward, I think we've had lots of changes in legislation, particularly around pharmacotherapy, that are likely to be sticking around for a while. And that's around sort of flexibility around take-home or non-supervised doses. Also, we've had a significant uptake in Australia, particularly in Sydney and Melbourne, around long-acting injectable buprenorphine. This has come at a really opportune time for patients in both cities, because it's been on market here in Australia. I think the second product was brought onto the market in April, and the first product, Buvidal, was brought on late last year, in 2019. So the timing of that has really meant that a lot of individuals have been able to access treatment that's been a monthly injection rather than necessarily going into a pharmacy to dose daily. And so in the context of that, we've really seen a big uptake in the medication. Next slide. In the context of what we're talking about today and thinking about what we're likely to expect going forward, I think in Australia, one thing we're looking quite closely at is what's happening with alcohol. This is a significant problem in our country, and definitely the #1 problem for drug and alcohol services nationwide. And overall, the start of the first wave, what we saw in our country was that there was a lot of stockpiling happening. There were queues at the bottle shops. There were a lot of people actually buying a lot of alcohol. But in terms of the actual consumption of that alcohol, it was a bit of a panic buying scenario. People didn't necessarily consume all that alcohol. So the actual consumption levels population-wide were relatively stable. But then as you know, time wore on over the last kind of 4 to 6 months, what we've been seeing is that overall, there's actually a group of people who have abstained through the whole period, and that group is a non-insubstantial group. But of the overall group of people who are reporting increased drinking, women are sort of disproportionately represented in that group. Next slide. And one of the reasons that we think that might be related to, and this is particularly Victorian data where we've seen the majority of the lockdowns being experienced, is that the mental health impact has been significant for women. for a range of reasons that I'll mention in a second, but I think the self-reported sort of symptoms that women are reporting are higher levels in comparison to men. Next slide. I think the range of reasons for that include the economic burden. We've certainly seen this extended sort of impact of lockdown being significant for women because they're overrepresented in a whole range of different industries that have entirely shut down during this lockdown. And we're also, like many other presenters have mentioned, we're seeing significantly increases in reports of family violence. So that's increases in calls, but also practitioners in the family violence sector are reporting increases in sort of the severity and the complexity of family violence presentations. So that includes, the preponderance of sort of isolation. In Melbourne, for instance, there's a 5-kilometre sort of zone that you're not supposed to be traveling outside of, and that's part of the reason why some of these presentations are so significant. There's certainly legislation and allowance for people to actually leave their homes, certainly if they've experienced family violence, but I think this has added a dimension of people being extremely isolated in the course of that. Next slide. I think this picture sort of says a lot, and I think it's been part of the piece for many women across the world. So I think part of what we're seeing in terms of alcohol is that women are 3 times more likely than men to report looking after children and taking on the child caring role during COVID. And this is, schools have shut down, childcares have shut down. And in the surveys that have been done over this period in Australia, having a child caring role, it was a significant and strong predictor of increased alcohol use in particular. Next slide. What we're also seeing is that this has become a bit of an opportunity for lobbying and for alcohol industry and marketing. And so a campaign that was done by the Cancer Council here in Australia and FAIR, an alcohol advocacy group, actually found that people are actually being presented with alcohol advertising on social media and online every 35 seconds. There's certainly been a lot of memes and things on the internet circulating around the use of alcohol, normalization of alcohol as a way of coping through this whole period. Next slide. So where that leaves us, I think, going forward, and in the theme of, I suppose, some of the talks that we're hearing about today, is trying to understand where this leaves us going forward. And I think what we're concerned about here in Australia is that during this lockdown, a lot of habits that have kind of been set in place can be cemented down. The Alcohol and Drug Foundation here has set up a campaign that specifically focuses on alcohol use and trying to bring light to people's kind of routines, behaviors, patterns of use that have been set into place during the pandemic and the fact that that might stay around for a while. I think that's my last slide. Thank you.
Shalini, thank you. Thank you very much. Very interesting presentation on alcohol and impact on women in particular, and people with an alcohol problem somehow might have faced more challenges during the early phase of the COVID pandemic. Who knows? But definitely we as professionals haven't paid as much attention to their needs as for those on opioid substitution treatment. Personal opinion, I might be wrong. All right, we have a lot of time for Hamid to present the progress of the ISAM Global Survey. Hamid, the floor is yours.
Absolutely. Hello, everyone. I'm really happy that we are back again together with this series of webinars that we started kind of several months ago. And I'm really happy to see kind of faces again and again, and people are doing really great jobs around the world. And it is really amazing, inspiring to see the progress. So what I'm going to do today, I'm just going to give you an overview about what we have done in the ISAM Global Survey on COVID-19 pandemic and substance use disorder. I'm just presenting on behalf of a large group of colleagues and collaborators that most of them are here on the webinar. So I'm just presenting on behalf of them. So if there is any specific comment that people are interested to add, just jump in and kind of add to the discussions and the kind of the data I'm presenting on behalf of a really kind of brilliant group of colleagues and collaborators. Okay, so let me see. Okay, so basically, as you know, we started with putting together something like a theoretical framework, an overview about what are the things that we are expecting to see in terms of the interaction between pandemic and substance use disorder around the world. So we made a specific position paper discussing about what are the challenges that we are thinking that we are going to face in the future. And this position paper has been cited many times during last few months. So the position paper was providing us with something like a theoretical framework about the questions that we need to ask. Because at that period of time, we didn't have any data. So we have been just based on the kind of expectations and previous experiences. So we have been thinking that what are going to be the major challenges in the future. So we started from this specific point. And I asked my colleague Panyan to just share the link of the documents that I'm sharing here on the chat space. So you can just go to the chat space and click on the links and see the papers that I'm sharing right now with you. So we started from this position paper, and then we developed a specific research protocol for a global survey. And you can find the details about the research protocols, and we published the research protocol. So the research protocol is already available, so people can see the research protocol. And then we moved forward and ran the global survey. Something like 1 month after the official announcement of the pandemic by WHO. So it was a really good time to just be able to assess what is the effect of pandemic around the world. And based on that, we basically developed 2 data papers from what we collected from that survey. The first data paper is out as a preprint in medRxiv from July 24th, and it describes the challenges for supply, price, and use, and some complications. So it provides an overview about the scene of substance use around the world and the challenges that people are facing. And then the second data paper is about how health sectors around the world responded to these challenges and the difficulties that people in different parts of the world are facing, and the challenges that they are facing in terms of how to optimize their treatment services. And we also provided many details in terms of even recommendations based on the data that we have, things that people need to consider, not only in this pandemic, but also in the next phases, and also probably future pandemics that we all need to be conscious about. So these are the two pieces, and we technically kind of published this one as a preprint something like 2 days ago. So it is out, and it is on medRxiv from something like a few hours ago. So it is really fresh piece of evidence. So people have just started to look inside and the details that we are providing. And I'm not going to basically spoil the entire message that we have in these 2 publications. I'm just going to give you a few pieces of the evidence that we published in these 2 data papers. But I highly recommend you to go to kind of the details that we provided inside. And as you can see here, we have a really interesting, nice group of colleagues here from different disciplines, different countries, contributed to this survey. And I really need to thank all of them to basically put this together. And I mean, obviously, you can see that people have done a really nice job to make that happen, especially kind of colleagues that I can see here. Alex, ISAM President-elect, Kathleen Brady, Mark Potenza, Shalini, Christos, all the other colleagues, Ali, Dr. Farhoudian, Ramin Radfar, Panyan, who is here. And I also need to kind of make a special thank to Mohsen, who is our data mining expert, who has done the analysis and provided all the figures that I'm going to show you. So it's a really nice, interesting group of colleagues and collaborators. And we also have a really nice group of young students and kind of researchers in their early career among the authors. So we try to also train the next generation of those who are going to run these studies. So it is not just senior people. We try to have a mixture of young investigators and senior investigators together to be able to run the study. And if I just click on this, probably can, yeah. So if you just find the paper, and this is the Europe PubMed, you can find the paper in Europe PubMed. And if I go to the paper, to the full text of the paper here, it is not published yet, so it is not peer reviewed. It is still in the process of peer review. So I hope that it would be peer reviewed and get published. But what we have here, if I go to the paper and details that you can see that we have provided, we have also made the list of those who have contributed to the consortium from different countries. So you can see here, we have a list of 177 contributors from 77 different countries around the world. So as you can see here, these are the names of the people who technically contributed to this survey, and we added their name as basically contributors or consortium contributors to the paper, and we have their affiliations. So we try to consider everyone who has contributed to this global survey, and that is going to be a culture that we are going to continue to do for the next global survey. So we are going to kind of try to have a large group of contributors and collaborators to be able to have a global sort of collaborative networks of addiction medicine professionals to be able to make this happen and kind of push that agenda forward. So that's kind of just to give you an idea about how we have group of colleagues here. Okay, as you can see here, we have collaborators from, as you can see, from US, from Iran, India. So this is the number of collaborators that we have. And there are countries that we do not have collaborators. So we do not have collaborators from basically Central Asia, this part of the world. We do not have many collaborators from here, this part of South America, that is another part of the world. There are countries here in Southeast Asia that we do not have collaborators. So I highly kind of encourage others, if you know addiction medicine professionals and experts in these parts of the world that we do not have representatives, please introduce them to us. And even you can use the chat space here or the email that I provided, isam.globalsurveys@gmail.com. So you can just send us the names of the people that you feel that they might be interested to contribute to that global survey. So I really like to kind of encourage others to see how we can make the map, have something like a better global representation of the survey. So that is one of the major missions that I have today, to encourage others to join us and be able to have a better representation about what is happening around the world. So that is one specific point. If you have a specific suggestion, you can do it right now. So you can just even put it under chat space, take something like 30 minutes of your time and just share whatever you can. Let us know in terms of kind of nominating people that could contribute to this global survey. So I'm going to give you an idea about the data that we have and how we try to process the data. They seem complex because we provided the entire kind of database in the figures. So in terms of the changes in alcohol and drug use, if I just want to give you a summary results of what we have, as you can see here, we have 177 contributors from 77 different countries. And this is the response that we have. Overall, as you can see here, as other speakers mentioned, as Kathleen has mentioned and other colleagues in different parts of the world, it seems that overall we have a significant sort of reduction in terms of major hardcore illicit substance use around the world. And probably an increase in alcohol, cannabis, and sedative prescription opioids. So that is the kind of the general conclusion that we have from the data that we collected around the world. But I don't like very much to just impress you by the quality of the data that we have and the kind of the size of the data that we have. I really like to show you the real data that we have, the challenges that we had inside the database. So I'm just going to give you some other pieces of information that we have in the data. So I provided another cut from the figure. I'm going to show you a few other pieces here. First of all, I'm not really a great fan of bar charts because I think that bar charts would not give you the details about the data that we have. What we tried here, we provided points for every single response that we recorded inside the database. So as you can see here, all these kind of points are representing one single response. So we try to show the real data, not just the beautiful bar charts that are showing the increase or decrease. So you can see the actual data. And as you can see here, for example, about alcohol, you can see that in general, we reported that there should be an increase in terms of alcohol use. But you can see there is a diversity among different countries. So like here, we have Greece, Indonesia, Iran. They have reported increase in the level of alcohol use. But from India, people reported a decrease in the level of alcohol use. An interesting part is that all 13 responders from India, they were in a level of consensus that the level of alcohol was decreasing in India. And it's quite interesting to see the level of consensus that people have here, or the level of consensus that people had here in Indonesia. Or as you can see here in Iran, there was one person who was thinking that the alcohol was decreasing. So we try to provide every single data point that we have to show the real data that we have in this kind of database. And as you can see here, there are other stories in other pieces of other parts of the world that you can explore, and there are many interesting details that you can get from the data that we provided. Just to give you a few other pieces of information from other parts of the world, as you can see here, in some other countries, we do not have that level of, let's say, consensus. Overall, we had a kind of a response of an increase in the level of alcohol, but we have significant variations in responses in some other countries, like what we have in UK or what we have in US. So we try to kind of provide a good representation of what we have, not just overall responses, but also each individual responses that we have collected from the survey. And this is true when we go back to kind of the entire figure. So you can go back and just see not only the below line that is provided, the overview, overall responses in terms of, okay, we have a decrease, we have increase in these domains, but also go into each individual countries and see how they have responded, and the number of people who have responded from these countries is also provided here in the graph. And we have the same process for all other pieces of information that we provided in these two data papers. So you can see here, this is about changes in alcohol and drug supply. Overall, as other speakers have mentioned, that overall it seems that we have a reduction in terms of the global drugs supply among different drugs, and that is a consensus that we had around kind of the different countries. Also about the changes of the price, as you can see here, this is the overall response. But if I just get focused to the all responders or all countries, then what you can see here is just in all responses, all countries, this is the overall increase in terms of the price for different sort of drugs that we had around the world. And also it is true about the stigmatization and mortalities, as other speakers have mentioned today about these challenges. So as you can see here, overall we have reports of increased stigmatization, increased alcohol mortalities, and drug mortalities. So that is what we have. And also about risky behaviors. Then we have decrease in the level of supply and increase in the price. As you can imagine, we have reports of, let's say, increase in terms of the risky behaviors that are related to substance use disorder. That could raise concerns for probably HIV/AIDS and other things that make concerns in the global level as well. So this is the first part, and then overall we ask people to report the severity of problems that they are kind of experiencing, or people with substance use disorder are experiencing in different countries around the world. And as you can see here, this is the global map. So countries like, let's say, US, Iran, China, they reported something like between 8 to 9. This is kind of something like a visual analog scale. There are countries that they have not been affected that much to the kind of the COVID at that period of time. So you can see that there are different versions of report to that. And there are countries that they reported they are more severely kind of affected by substance use disorder. But this is the way that we collected some sort of, as you can imagine here, these are going to be to some extent subjective responses, how people perceive the challenges that people are experiencing from substance use disorder. And then we have the second paper. What I explained you was the first paper. So you can find the first paper and what discuss about it in details. And then there is a second paper specifically on treatment and harm reduction services. So we discuss about services and what is happening with services around the world. And on that paper, we discuss about availability and access to the treatment and harm reduction services in details in different countries around the world, other services that are provided, something like needle syringe exchange programs, our countries providing PPE for substance use disorder patients, so different things that we have in countries around the world. I'm not going to go to the details of those items, so you can see the responses and the challenge that people are facing around the world. Overall, what we have is, as you can see here, in different levels. This one is specifically on vulnerable population, but we have in most of the services, people are reporting the services that are facing challenges. So something like over 50% of the services for vulnerable people or other treatment services around the world are facing challenges. And we discuss about these challenges and how these challenges should be addressed and how different kind of treatment services or treatment service providers or policymakers need to address these concerns. And then the policies and also how overall different countries responded to the pandemic and what are the dimensions of response that should be considered. When we make a national policy, what are the dimensions that we need to consider when we want to make a flexible treatment services or health response to the COVID-19 pandemic? What are the dimensions that should be considered? And also, as you can see here, the overall quality of health responses as being perceived by responders. And as you can see here, there are countries like China that they reported they are really happy with the services that they are providing. And there are countries that are not really happy with the services that they are providing. So as you can see here, there is a variation in terms of the how people are perceiving the quality of health response to COVID-19 pandemic around the world. Okay, discussing about what are the things that we are going to do in future. So what would be the next steps? How we can move forward from this point. First of all, we realized during last 3, 4, 5 months of working on this specific line of project that there are definitely lots of great potentials for ISAM to be able to run global surveys in a really good quality. And that is going to be a great advantage for ISAM. And we can do that as something that is going to be really helpful for the addiction medicine community around the world. So we are going to extend the global server network and we are going to expand that. We definitely need to have subcommittees discussing about what are the questions that we need to ask around the world. And we need to have experts to ask what is the best question regarding stigma? What is the best question regarding the mortalities and fatalities and the challenges that we have for measuring these things around the world? And we also need to develop even a specific research methodology for being able to run global surveys. And there are specific research challenges and even analysis challenges, how we do data analysis for these global surveys. And we have data from something like 100 countries, from 200, 300 responders, how we are going to do analysis and what are the challenges for data analysis on that level. And one of the most important issues, what are the hypotheses that we want to be tested with these global surveys? We cannot just go and ask hundreds of questions from people without having a specific hypothesis or a specific questions. So we are going to encourage everyone who is attending this webinar or this series of webinars, those who are going to see the YouTube video that we are going to provide, to just join us and share the questions that they like to be answered in the global level. And we are right now providing and planning for the follow-up survey, and we are looking for, basically we are designing the follow-up survey. We are looking for those who are interested to kind of join the subcommittees, ask questions, even contribute to the research methodology. And I think that is going to be something that is going to receive lots of attention within ISAM. And we hope that at the end of the day, with all these, let's say, evidence that we are providing, we can have best practice guidelines based on the evidence that we are collecting around the world. That is something that I think is going to be highly needed. As you can imagine, there are packages, but what we have adapted for COVID-19 is going to be challenging. As you know, we have, for example, a series of neuroscience-informed psychoeducation material for people with substance use disorder with different cartoons, but how we can adapt them to material that are going to be helpful for COVID-19 patients. And so we try to develop some specific neuroscience-informed material for COVID-19 patients that are freely available. And I will ask my colleagues to just share the links to these materials so you can find those materials. But the challenge is, okay, when we develop these materials, how we can kind of optimize them based on the evidence and how we can see how these packages are going to be used around the world in different platforms. So just now we have the floor open for further discussions and see how we can move forward together to do something that is going to make a global impact and help addiction medicine professionals around the world to provide better services for their patients. Thank you for your attention.
Thank you very much for that. Really hot off the press, it seems like. Few hours ago and straight to the webinar, so you heard it here first. Really interesting data, obviously, that you've collected, and as you pointed out, a really unique source of information. I suppose we're hearing this from professionals working at the front line from around the world in addiction services. So it's a really unique kind of perspective, I think, in terms of what people are actually seeing. And I think the other advantage is, that perspective that's been a longitudinal perspective through the piece with the different waves that you've been able to conduct. So really interesting information.
Alex, do you want to add anything to that?
It's always very good to be asked. No, I'm a firm believer of the process as much as the outcome. And what it did for us in the last 6 months is that we learned a lot as much as we, worked a lot. And I think, sort of the global survey has all sorts of relevance right now, especially when we have been working very closely with the United Nations, WHO, and the EMCDDA, amongst many other international organizations, to support them with their own pieces of work. And when you would consider or assume that they have the available respondents to inform them, when actually you realize that this global survey has actually crystallized the knowledge base of clinicians, which are sometimes forgotten throughout this process, who are, as Shalini said, the frontline clinicians. But I think it's also important really to realize that this is a framework, as Hamed has intimated, in order to understand better potentially training needs, potentially educational material, and other similar mapping exercises. I'm aware Gabriella's here, and I remember 10 years ago Gabriella trying to do a survey around addiction medicine training, and I think it took you about 2 or 3 years to do that. And even that, you weren't able to have that global reach. So I think that they're important things to consider, but also to refine, and we need to do it well. My worry about information is, in this day and age, is information overload. and data collection for the sake of collecting data, which really doesn't make much difference to the frontline clinicians and our patients that we serve.
I think we've got all the information of the team in Hamid's slides, and they'll be available in the recording too. So feel free to follow up with the global survey team if you've got questions, or if you want to suggest colleagues who might want to be part of the network. So on that note, we've got just a couple of minutes left. If anyone has any other questions, feel free to pop them through in the chat. The slides and things will be available in the recording usually within a couple of days, that we will circulate to anyone who's registered, and also through our social media account, so watch out for that. As Christos mentioned at the start, we had planned for this to be the last COVID-19 webinar, and I think we will probably leave it at that being the last COVID-19 webinar. That does not necessarily mean, obviously, that the impact of the pandemic is over. It's probably that we're all sick of hearing about it, largely. I think what that means, though, is the next time we'll probably meet in this sort of space virtually will likely be at the ISAM Virtual Congress. So ISAM CSAM Joint Congress is coming up in November, and there's a whole range of really interesting symposiums. Some of them are being run by ISAM and by the PPIG group as well, by several members. And then there's also the really great opportunity to log in and watch presentations also from CSAM and from what's happening across Canada through this whole period. So watch out for that. And on the webinar link, you will have seen that there's a link through to the ISAM Congress registration and website. The program is now available, I believe, for all of the Congress, so you can figure out what that is in your time zone. You can figure out whether you're presenting like I am at 3 a.m. So that will be a fun time. So if there are no further questions or no comments, we might wrap up there right on time. So thank you again for joining us in this last webinar, and hope to see you again at Congress. Good night, everyone.
Thank you.